going to be talking about is data strategies, a state approach to having healthcare workforce data, including comprehensive data on family medicine physicians within a state, okay? And how that data is collected in conjunction with regulatory processes within a state and under statutory authority it's collected, and then how those data are maintained through a state academic partnership, by the way, with the Department of Family Medicine, and turned into information that drives healthcare workforce decision-making within a state. So that's what we're going to be talking about today. And again, total disclaimer, I am not a family physician. I am a dental hygienist who happens to be a health policy and health workforce researcher. So I'm going to start to tell you kind of where I'm at. I am appointed in family medicine, and I serve as the director of a departmental-based center called the Bowen Center for Health Workforce Research and Policy. Actually, Otis Bowen was a former chairman of family medicine at Indiana University, and he was a former governor of Indiana. So he was a family doc who was the governor of Indiana previously, and he was the secretary of HHS for a while at the federal level. So I have the great honor of serving as a director in a center that has a small endowment to Dr. Bowen. And the center was established in the 1990s. It originally did basically like family medicine education research back in the 90s and the early 2000s. And we had faculty retirements and departures, and it kind of lost its focus, and it lost faculty leadership. I came in 2014, and I came fresh out of a dissertation that looked at the impact of state policy on implementation of federal programs in underserved communities. Of course, being a dental professional, my dissertation was focused on dental access at FQHCs nationwide and state policy environment for dental hygienists. But my broader area of research and interest was around how are we even collecting information and using it to inform where we need providers to go? What types of providers or professionals or workers do we actually need? How are states even going about doing that? And the answer is they're largely not, okay? And so actually the Department of Family Medicine recruited me because I had a deep interest in healthcare workforce matters. And just to be very honest, I don't know, how into health policy all of you are, but Indiana in 2014 was in the midst of negotiating our Medicaid expansion, which is not, it's like an alternative to Medicaid expansion called HIP 2.0. Our governor then at the time, who was now the former Vice President Mike Pence, he was working with his administration to get our Medicaid expansion passed. And next up on the agenda, after we got waiver passage for our alternative to Medicaid expansion, was how are we going to know if we have enough healthcare workers to serve our newly insured populations? So healthcare workforce, top of the agenda in our state leadership. I just finished my dissertation in healthcare workforce related research. Our School of Medicine and our Department of Family Medicine said, come here. We will give you resources. We want you to create a health workforce center that's going to support our state and become regionally and nationally recognized for expertise in helping to support and drive state healthcare workforce policy. So I was able to work with our leadership. It was the right place, right time. And in 2016, after 2 years in my position with our Department of Family Medicine, I was able to negotiate with our dean at our School of Medicine the renaming of the Bowen Research Center to the Bowen Center for Health Workforce Research and Policy. And I was able to negotiate a standing contractual arrangement with the state of Indiana to underwrite support for healthcare workforce, basically data and reporting and technical assistance to the state of Indiana. And we're going to go into kind of logistics of that because I have a feeling you'll be interested in kind of more of that. But just wanted to give you a heads up. So 2016, this research center that was named for Doc Bowen in the 90s, rebranded to become Indiana's state health workforce research center at Indiana University in our Department of Family Medicine. Our current portfolio of projects, it is heavily focused on state service projects, and I'm going to tell you a lot about the data work we do because I think you're going to be most interested in that. But actually, surprisingly enough, over the pandemic, all of a sudden the floodgates opened, and in addition to doing state work with our state government in Indiana, we've had our hospital association, professional associations like our state medical association, our Center for Nursing, various other entities have actually come to our center now for support through health workforce related assessments. And I don't have to, if I have time, I'll go into those. We're working with our primary care association on expansion and roadmaps for expanding health professions training in health centers, all sorts of different projects, with the foundation being our team has the expertise and the access to the data to basically drive any healthcare workforce decision making in the state of Indiana. We're engaged not only in service projects for our state with external stakeholders, but we also, over the last 3 years, I've been able to build a portfolio of collaborative research studies across our School of Medicine, School of Dentistry now, our School of Social Work, all based on healthcare workforce related questions or lines of inquiry. So this data is now become an engine for scholarly advancement at IU as well. Also within the Bowen Center, and then also external to the Bowen Center, over the last several years, I've begun to work with other states who are very interested in what's going on in Indiana with healthcare workforce data. And so I now actually serve as an expert consultant to the National Governors Association, and I have an ad hoc consultancy with them to work with governors and their administrations to develop strategies on how they might leverage state processes to collect data to inform and drive their decision making in these spaces. And of course, the way that you frame that depends on if you're in a red or blue state. It's either an access to care and a public health issue, or it's an economic and workforce development issue, and you got to have a healthy population if you want big manufacturing companies to come here. So it can be framed both for the red and the blue states and fit any type of discussion. So that's the Bowen Center. Who we are now, I just put the slide on here. It's like our stock slide. But we have a long name. We go by the Bowen Center, but it is Bowen Center for Health Workforce Research and Policy. It's very important to me that both the research and the policy are in there. Within that, we also don't have this in our title. A huge part of what we do is data. And I'm actually going to spend the majority of the time talking about the data with you today, and then maybe weave the thread of how that feedbacks into the research that we do at the university and the collaborative projects, but also then obviously how it drives policy discussions and ultimately has informed legislative initiatives increasingly over the last several years in Indiana. Who we are, because I do think people frequently ask, who do you have on your team to do all of this work? We are very small and mighty. I just have our leadership team here. So there's myself. My background is in health policy and management. My minor is epidemiology, and I got my doctorate from a School of Public Health, the Department of Health Policy and Management. My colleagues that are with me that are my leadership team, I have a health policy analyst that I was able to recruit when she was incoming in 2014 to the MPH program at our university, at our School of Public Health. And I've been able to kind of mold her into a healthcare workforce policy analyst expert who's now increasingly getting opportunities to work at the national level. So I hope I don't lose her. Fabulous. I also have a colleague, Sierra Bond, who's a health services research analyst and epidemiologist. Sierra oversees all of our data work that I'm going to be talking about and our research management. So all of our research projects and research portfolio. And then we do have a program manager who basically helps tie all the administrative processes together with the university, because I think almost all of us are academic based, and the layers of administration are huge. So having someone to navigate that is extremely helpful. Additional team members, we have a research coordinator full-time. We have a research assistant at 0.75 FTE. I have a biostatistician at 0.4, and then we have a database architect. The big bucks go to that position. I will just tell you for the data work that we're going to be talking about, and that is at 0.8 FTE. So I want to pivot and I want to talk about the life cycle of health workforce data, because I think that's what you're going to be most interested in. And I want to talk about that life cycle in 3 areas. The first is data collection. Then the second is data management and analysis, and the final is data reporting. And so I'm going to go through and kind of explain the work that we do in each of those areas. In the state of Indiana, for a couple, at least 2 decades now, Indiana has asked supplemental questions at the time of license renewal for physicians, for nurses, for dentists, for pharmacists. Back in the early 2000s, those were paper surveys that were mailed out. This is back in the day when people still mailed in their renewal applications for their licenses primarily. Of course, over the last 2 decades, we are now to a point that like 98% of licensees in the state of Indiana all renew online. And we're moving towards having initial license applications for our regulated occupations go completely online as well. And so starting about in 2010-ish, Indiana started to implement supplemental questions that used to be mailed on a survey format into the license renewal process that's web-based for licensees in the state of Indiana. And so let me tell you what that means. That doesn't mean that when you go to renew your medical license, you go to your attestation, you know, have you had any disciplinary actions that might bar you from practicing medicine, or in my case, dental hygiene, and you say no. And then it goes on to the next, and it has a series of questions. The supplemental questions that I'm going to show you are seamlessly embedded, coded into the renewal process, so that when a physician or a dentist or whoever is renewing their license is renewing their respective license, it's super streamlined and easy for them to say, yes, I practice clinically. Here's, you know, my specialty. Here's et cetera, et cetera, et cetera. So it's seamlessly embedded into the license renewal process online. Currently in Indiana, these questions, the supplemental tools, are implemented across the board for licensed health occupations. And in fact, our state is so pleased with the data they're getting, they actually are now requesting that we work with basically the state bar and engineers to make sure they get all of this data on all other licensed or regulated health occupations in the state. So we implemented these survey questions at time of renewal, seamlessly embedded about in 2010. I stepped into my role in 2014. At that time, the questions were voluntary, meaning that a person could, as they're going through the process of renewing, they could say, oh, you're asking me whether or not I actually practice clinically in the state of Indiana. I don't want to answer that. I don't have to answer that. Okay. In 2018, after about 9 years of advocacy and working with the State Medical Association, Dental Association, nursing, getting grassroots advocacy, we had a bill pass. And I have the link to that at the bottom. I'll send these slides out to you all afterwards so that you can see them. But that bill, it basically authorized our licensing agency, because we have an umbrella agency in the state of Indiana, to basically require licensees to provide this supplemental information at the time of license renewal. So that made the questions from voluntary, meaning I don't have to say if I clinical practice in the state of Indiana, to required as a condition of maintaining your state licensure. Okay, so that was implemented in 2019. We now have for our web-based renewals, which I said are about 98% of our licensees at this point, we have 100% participation from licensees in the state of Indiana. This slide, those professions that have asterisks, they fall under the statutory requirement. There is interest, as I've said, in expanding the statutory requirement to provide that information to other health occupations, and just broadly because the state is saying, wait a minute, we've used workforce and labor data for years, and it absolutely doesn't really tell us what people are doing. And if you want to get back to pipeline planning, a doctor is not just a doctor, right? A family medicine physician is very extremely different than a neurosurgeon. They do different things, they practice in different areas, they contribute to healthcare and to our health system in different ways. And so our workforce planning has to account for those differences, and we can't just count the heads. So in the state of Indiana, we now have that data. The supplemental data, I have it on the right-hand side. It includes demographics. This is political in some states. They, you know, when I've been working with some administrations, they don't think that any demographic data should be required. My argument to them is we have increasing conversations regarding diversity and representation within the workforce, and how the heck are we going to plan or know where we stand on diversity unless we are able to know where we're at and set benchmarks and work towards them. And so very quickly, states are moving towards saying, yeah, we do have to have demographic data so that we understand diversity and representation within these professions. Also, there is educational data that's collected, and I'm going to go into that in just a little bit. Employment data. So, you know, it varies by profession. For physicians, they're asked up to 3 practice locations, the setting that location represents. So inpatient, outpatient, FQHC, you know, et cetera, et cetera, et cetera, VA hospital, all of these different settings that they can select. Telemedicine participation is asked. Safety net participation, Medicaid sliding fee scale acceptance. And by the way, these questions are all reviewed by and aligned with our federal shortage designation requirements for data for the state of Indiana. So we're able to extremely, as a state, efficiently and effectively know where our health profession shortage area and medically underserved areas are, because the data is automatically collected now every biennium to support those processes. So there was actually cost savings to the state. This is an example of the tool, and I'm going to be sending this to you. It's hyperlinked. And on our website, the Bowen portal, every tool, every survey tool, so these are the supplemental questions, are publicly available. We make them so that other states or stakeholders can look at them to see what type of data Indiana collects at time of license renewal. The survey tools do vary slightly from profession to profession, but the demographic questions and there are set of what we call minimum data set questions that are consistent across all occupations so that we can do cross-occupational comparisons. This is just an example of how the questions are seamlessly embedded. Every state has different software programs or platforms that they use for license renewal. This is Indiana's, and you can see it's just literally seamlessly embedded. And the majority, with the exception of the practice setting or the practice location, the actual street address of a practice, all of it is click, click, boom. So it takes less than 5 minutes on average for a physician that only has one practice location to complete. If they have multiple, it can take up to 8 minutes. So for data management, I'm going to kind of gloss over this because it's the highly technical stuff. When I present on this, I basically tell stakeholders that what we've created is a library. We've created a data library for Indiana's healthcare workforce. That library is a relational database. And in our library, we have different collections, just like you go to your library, or now I guess we all use Libby or another app probably to go to the library, but we still go to the library sometime, right? And in the library, you got the youth collection, the adult collection, the fiction collection, the nonfiction collection. In the Indiana Health Professions Library, we've got the physician collection, right? And in the physician collection, each biennium, we now have books or data sets that we're adding. So we have the 2015 physician data, 17 data, 19 data. We'll be adding the 2021 data soon to it. And so we're building out all these collections that will eventually enable and allow us to be able to track longitudinally in depth where physicians are going, how practice is changing from female to male differences in characteristics. So very high resolution information. And of course, we're just adding new additions each biennium. So you can imagine this is getting big really quick. We license 120,000 RNs in the state of Indiana. We have data on them going back to 14. So the database is like every year is expanding and growing. But we're working with a top database architect at the university to make sure it's structured in a way that it's super easy to access and use. And so I think, did I miss a slide? No, that was it. Okay. So for data reporting, and I'm almost done, and then I'll take a breath and you guys can ask any questions that you might have. Our team, the data is, we work with state government. Since the statutory requirement for these questions was implemented, in Indiana, I told you that in 2014, I was recruited. I worked with our governor, who then became vice president. They were very interested in healthcare workforce planning. At the same time as I was able to negotiate a contractual agreement with the state of Indiana and Indiana University School of Medicine, the Department of Family Medicine, for a contract to support healthcare workforce data and all of these different reports and things that I'm going to share with you. We were also able to advise and work with our governor to establish a health workforce council. That is called the Indiana Governor's Health Workforce Council, and it is chaired by our Department of Workforce Development, which is a very strategic advantage in the state of Indiana, because the majority of the time these conversations are led by departments of public health that just quite frankly are underfunded and don't have the ear of the governor the same as a labor agency does, okay? And so in Indiana, part of what we did at the same time that we were saying we need data to inform and drive decision-making, we were also saying that we need a body, right, that can use this data, that stakeholders can come to bring their issues, and that this body has to have some type of authority to make recommendations that can guide executive branch or legislative branch decision-making. That is our Governor's Health Workforce Council. I serve as an appointee on that council as the state expert for healthcare workforce matters, okay? And my center, my team, staffs the council on behalf of our Department of Workforce Development. Because our Commissioner for Workforce Development is driving the bus, and our Secretary of Health, our Secretary of Social Services, they sit on it, the conversations in our state are focused on and balanced between public health, access to care, social services, and workforce and economic development. And I believe that that has been a strategic advantage to continue the momentum across administrations. And even now through, obviously the pandemic, public health was the top priority. But you know, if you work at all with state government, it's extremely hard to get governors interested in for any long-term initiatives in public health. Quite frankly, it is. And it's hard to make the case for prevention. But it is never hard to make the case for workforce development, labor, and economic development if you can tie healthcare workforce or, for example, family medicine discussions to that. I'm telling you all of this because those survey tools, right, the supplemental questions are now required under law. So you can imagine that very quickly stakeholders are saying, who's deciding what questions are asked of our physicians now that it's under law? Well, it's our Governor's Health Workforce Council, which is high-level appointees. So that body serves as the approval entity for the supplemental questions and kind of acts as that stopgap so that no one can just come to our licensing agency and say, hey, we want these questions added. There's actually a process for promulgating and approving changes to that through our council. The slide that I have up today or right now, it's just showing you trends in what response looked like over the years. And you can see that even before Indiana had the statutory requirement for licensees that renewed online to provide that information, we still had a high percentage of our physicians that responded to the surveys electively. We credit that to those questions were embedded, right? So the majority of people, when you're moving through your license renewal, okay, unless you're someone who's looking and saying, do I really have to answer that? The majority of people, it's just click, 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 because it's easy. And so we had fairly high response rates. And you'll see in 2017 what the response rate was. There were 27,400 approximately licensees, 22,000 responded to one or more question. This is the big difference, okay? And 11,000 were able to be identified as clinically practicing and providing direct patient care to Indiana residents. That's a huge difference, 27,000 to 11,000. In 2019, after the statutory requirement for physicians to provide this information, you can see we had 28,400 licensed physicians that renewed. Almost 27,000 of those renewed their licenses online and therefore fell under the requirement to provide their answers to all the supplemental questions. Of those, 17,000 are clinically practicing in the state of Indiana and providing direct patient care to Indiana residents, either directly in person or remotely through telemedicine. I put that qualifier on because we're able to now look at physicians based in California or Ohio or Pennsylvania or any of your states that hold a license in Indiana and in fact provide direct patient care through telemedicine now, and we're able to track that for our state. There are links here. I'll send these out. You can check out all of these resources, but they're all available on the Bowen portal, which I'll show you in just a moment. In addition to creating reports, and we do policy briefs, I'm going to show you our website. We've created hundreds, literally, of resources over the last 6 years for the state of Indiana. We also have data visualizations and dashboards. And so I just put 2 examples on. These are our new, you guys are seeing them in like hot off the press format. We're getting ready to launch new dashboards for physicians. And let me get through this and I'll see if I can go live to the dashboards. What they'll let users do, it'll be completely public, open access. This will take that data that is provided at time of license renewal and enable users to play around with it and customize it all the way down to family medicine. So I'm going to show you what that looks like in just a moment. You can see on the right hand side, the left hand side is actually what we're calling our geographic supply dashboard. And this is all active. I'll bump over to the active beta site for you in a moment. The left hand side is our county map. This is looking at primary care specialties. And so you can see the color gradient is the population to provider ratio. Green is good, red is bad. As you go towards red, it's higher population per primary care physician ratio. On the right hand side, this is a new strategy that we developed where we're looking at urbanicity or rurality on the bottom, on the lower horizontal axis. So as you go from right to or left to right, sorry, I get those mixed up in my mind. You're going towards more rural, and we classified it using root codes. I'd be happy to tell you what those are. If you don't know, we can do that later. And so each county is represented by a circle, and we're able to present the root code average in the blue bar, the statewide average you'll see in the dashed black, and then the primary care benchmark defined by HRSA or in the Federal Register and implemented by HRSA for the primary care HPSA designations. You can see that benchmark on the screen. The right-hand side I thought you'd be interested in because these are our educational dashboards. So for physicians, the left-hand map of Indiana and the contiguous states is showing the number of physicians that reported completing or receiving their medical degree in the state of Indiana and our contiguous states. And then on the right-hand side, that's residency reported completion in Indiana or in contiguous states. So this data is being used. I could spend hours talking with you guys about all of the different data work that's going on, and I know that's not what you want. But health workforce needs assessments, it's increasingly being used. Our work has blown up over the last 2 years. Shortage identification, that's the federal shortage identification, but we're doing service area shortage analyses now for hospitals, health systems, FQHCs. Obviously, medical education and GME planning, expansion, and evaluation. We're working with our medical school to do an evaluation of in-state retention now, to a level that they've never done before. So the standing normal had been exit surveys to report. We now are able to track people and find out where they're practicing, and if they stayed in Indiana, are they in an underserved? What I didn't talk about is we also have MOUs that enable us to link to Medicaid data. So we're able to look at who's providing Medicaid. Obviously, all these data are reported out in the aggregate to protect the professionals, but they're incredibly powerful information to inform conversations. I'm just going to show you, the last thing I'm going to show you is, can you guys see the Bowen portal right now? Do you see the slides? Okay, this is our website, and feel free to check it out. It's super easy to go to, bowenportal.org. The workforce dashboards, that you'll find those on the tab, but they're a work in progress, so you won't be able to access them at this point. That's coming soon. Those are the dashboards that I showed you the mock-ups of. But if you are interested in any of our reports or resources or the survey tools, you can access all of those under our publications tab, and you can select filter, and you can select physicians and you can select, survey tools. All of our resources, reports, presentations, all of those are publicly available online and accessible. And I'm not going to spend a lot of time, but we also do a lot of policy consultation with the state of Indiana and different people for healthcare workforce matters. And I haven't even been watching the time, so I apologize if I went over. I'm happy to answer any questions that you may have. I know this was a load of information, so.